I have skipped cardiology for now and the resuscitative procedures. We will do them in detail later. Coming to respiratory disorders, let's define some terms. What is dyspnea? Dyspnea is short of breath or difficulty breathing, breathlessness or not getting enough air. मतलब लोग बोल सकते हैं कि उन्हें सांस नहीं आ रहा, जैसे दिल्ली वाले लोगों को सांस नहीं आता, सेम. Dyspnea is mostly caused by pulmonary and cardiac diseases. Tachypnea is fast breathing. Orthopnea is dyspnea in a lying down position. It is mostly due to LV failure, diaphragmatic paralysis, and COPD. Then there is paroxysmal nocturnal dyspnea. It is a severe form of orthopnea in which the patient awakens from the sleep, prompting an upright position, and when the patient stands up for some time, he gets relief. Trapopnea is dyspnea on lying to the one side. For example, left lateral में आपको dyspnea हो रहा है, that is trapopnea, but right lateral में नहीं हो रहा. Trapopnea occurs when one lung is more diseased than the other and the patient lies on the side of the more affected lung. For example, if your left lung is having pneumonia and you lie on the left side, you will have dyspnea. Patient has dyspnea because what we actually wanted, we want the blood to flow towards the normal lung. But when we lie down, lie towards the affected side, the blood flow increases to the affected side and reduces to the normal side. So the normal side has VQ mismatch and we have dyspnea. So how do we remember it? ट्रैपोपनिया का ट याद रखना. टूटे हुए लंग की तरफ लेटने पे ट्रैपोपनिया होगा. ठीक है, टूटे हुए लंग्स की तरफ लेटने पे ट्रैपोपनिया होगा. Platypnea is the opposite of orthopnea. It is a dyspnea in upright position. Is it due to the loss of abdominal wall muscle tone seen in liver disorders? Hyperapnea is deep rapid breathing, basically hyperventilation due to metabolic acidosis. Ventilatory or respiratory failure. What is distress? First is distress, then there is failure. So respiratory distress is used by physician combining the patient's subjective sensation with dyspnea, and we see the signs indicating difficulty breathing like low saturation and use of accessory muscle, some tachypnea, etc. Respiratory failure occurs when lungs and ventilatory muscle cannot move enough air in and out of the alveoli to adequately oxygenate arterial blood and eliminate carbon dioxide. What is failure? Failure is despite doing your maximum effort, you cannot score sufficient marks. So in respiratory failure, despite doing the maximum effort by the patient's muscle, breathing, diaphragm, etc., still the patient's oxygen demand is not getting met. So that is respiratory failure. What are the common causes of dyspnea in emergency? The most common causes are obstructive airway disease like asthma, COPD. Then there is heart failure. Then ischemic heart disease, pneumonia, and psychogenic. What are the most immediately life-threatening causes? They are upper airway obstruction by foreign body, angioedema or hemorrhage, tension pneumo, pulmonary embolism, neuromuscular disease like myasthenia, GBS and botulism, and fat embolism. So basically upper airway obstruction, tension pneumo, pulmonary embolism, neuromuscular paralysis. Then there is hypoxia and hypoxemia. How do we know the content of oxygen? Arterial oxygen content. So it is 3 into 10 to the power minus 3 into PO2 plus 1.38 into hemoglobin into saturation. Just remember this formula. Arterial content of oxygen is 3 into 10 to the power minus 3 into PaO2 plus hemoglobin into saturation into 1.38. 3 into 10 to the power minus 3 into PaO2 plus 1.38 into hemoglobin into SpO2. What is the delivery of oxygen? Delivery is cardiac output into content. Oxygen delivery is oxygen content into cardiac output. What is hypoxemia? What is the definition? It is an abnormally low arterial oxygen tension which is PaO2 less than 60 mmHg or less than 8 kilopascal. Severely anemic patients suffer tissue hypoxia despite normal PaO2. Why? Because the hemoglobin is low. 1.38 into hemoglobin into saturation. So even if everything is normal, if the hemoglobin is low, we are going to have hypoxia. What is relative hypoxia? It is the term used when the arterial oxygen tension is lower than expected for a given level of inhaled oxygen. So if you are giving a patient a 60% oxygen, 60% FiO2, and still the patient has somewhat around 70 PO2, that is not expected because 70 to 60 is mostly expected at room air. So there is relative hypoxia. How do we calculate it? By calculating a PF ratio. What is relative hypoxia? So the patient has low oxygen, low PO2 for the given FiO2, means low PF ratio. The PF ratio is poor. Relative hypoxemia is calculated by calculating an arterial alveolar oxygen gradient. At 21% room air, 760 millimeters of mercury at respiratory quotient is 0.8 for a typical mixed diet. So A gradient is 149 minus PCO2 by 0.8 minus PO2 or 145 minus PCO2 minus PO2. You can remember any one formula. 149 minus CO2 by 0.8 minus PO2 can also be given because respiratory quotient is 0.8. What is the target arterial oxygen gradient in a person? It is 2.5 plus 0.2 into age plus minus 11. So for me, what will be the target? 2.5 plus 0.2 into 26 plus minus 11. 5.2 plus minus 11. So it's a very wide range, as you can see. Remember, DLCO is decreased in emphysema, DDE, DLCO decreased in emphysema, while it is normal in chronic bronchitis. Why? Because in emphysema, the alveolar barrier is damaged, while chronic bronchitis, it's just the disease of small airways and not the alveoli. Alveoli are normal. Now we will learn about approach to hypoxia. So as we have discussed, what is hypoxia? It is abnormally low arterial oxygen defined as PaO2 less than 60 and or 8 kilopascal. Okay. So hypoxemic respiratory failure is there. You find a patient with hypoxia. Where should I write it? You find a patient with hypoxia. First calculate their AA gradient. Either it can be normal or it can be increased. If A gradient is normal, that means that the alveoli are fine. Okay, it's either the patient is not breathing or there is some pathology which is not involving the alveoli. So then we will see the CO2. If it is CO2 is normal or increased. If the CO2 is normal, that means either we are providing patient less FiO2 by being at high altitude. So just bring the patient below altitude. The problem is in the environment, not in the patient. Patient is completely fine. If the CO2 is elevated, give the patient. If the CO2 is elevated, means the patient is having hypoventilation. Hypoventilation causing CO2 retention. And if the A gradient is increased, it is an alveolar pathology. And we need to check by supplying supplemental oxygen. Does it improve with supplemental oxygen? Yes or no? So if it improves, that means there is a VQ mismatch. If it does not improve, it is a shunt. Shunt is there is no ventilation but perfusion is present, and dead space is a zone where ventilation is there but perfusion is not there. Shunt mein ventilation is not there, perfusion is there. So what will improve with giving oxygen? It is simplified in this diagram. If the patient is having hypoxemia less than 60, you calculate A gradient. It can be normal or abnormal, normal or increased gradient. Normal gradient is found in two places. If we have hypoventilation, so we will find increased CO2 and reduce FiO2. And if there is reduced FiO2 नहीं मिलेगा. If the A gradient is normal, we will find PaCO2 is normal or not. If PaCO2 is normal, the lungs are normal. You're just providing him less oxygen by being at high altitude. If the PaCO2 is increased, it is hypoventilation. Increase the respiratory rate of the patient and or tidal volume of the patient. Basically increase the minute ventilation. Increase the minute ventilation for causing CO2 washout. If the A gradient is increased, we need to give supplement oxygen. If it responds or doesn't respond, remember, shunt doesn't show improvement with oxygen. So shunt shows no improvement with oxygen. If the patient is showing improvement, we need to see if it is more than 50 millimeters of mercury rise or less than 50 millimeters of mercury rise. If it is more rise, it is a diffusion limitation, example fibrosis. And if it is a less than 50 mm of Hg rise, it is a VQ mismatch areas like COPD. Now, why shunt will not improve with providing oxygen while VQ mismatch will improve? Because in shunt there is no there is no ventilation, right? So even if you provide oxygen, the alveoli which are already closed will not open further. While in VQ mismatch, ventilation is there and some perfusion is also there. So if we provide oxygen to the ventilated area with more oxygen, it will get carried. Shunt is an area with no ventilation only. So if the alveoli are closed, no matter how much oxygen you will provide, it will not help. Shunt can be anatomic and physiologic. Anatomicals are intracardiac shunt causing mixing of oxygenated and deoxygenated blood, and physiological like perfusing the non-ventilated alveoli in ARDS. It is given in Tintanalis. Hypoxemia results from 5 mechanisms. First is hypoventilation. You will find normal AA gradient with increased CO2. Right to left shunt. You will find increased AA gradient, which will not improve with supplemental oxygen. A hallmark of right to left shunt is the failure to improve response. A hallmark of significant right to left shunt is the failure of arterial oxygen to rise in response to supplement oxygen. Then there is a VQ mismatch like in COPD patients. VQ mismatch occurs in pulmonary edema and pulmonary embolism, COPD. Then there is diffusion impairment in lung fibrosis cases. You will see more than 50 mmHg increase in PO2. Then there is low inspired oxygen in वो patient था ना, कौन सा था, low inspired oxygen high altitude patient. What is cyanosis? Cyanosis is bluish discoloration of the skin and mucosa due to increased amount of reduced hemoglobin more than 5 gram per dl. Remember, the more than 5 gram per deciliter is an absolute amount. So if the patient has a hemoglobin of 10, still he needs a 5 gram hemoglobin, 5 gram of reduced hemoglobin to appear cyanosed. Similarly, a patient who has 5 grams of hemoglobin also requires 5 gram hemoglobin to be reduced to appear cyanosed. So you can see the polycythemic patient will falsely appear cyanosed, while anemic patient, despite having hypoxia, will never appear cyanosed. Patients will not respond to supplement oxygen in right to left shunt. What are the causes of hypercapnia? So it can be majorly divided into airway, lungs, muscles and CNS disease. So muscles, like there is thoracic cage disorder, kyphoscoliosis, morbid obesity, hypoventilation. Lung causes, patient has asthma, bronchitis, emphysema and restrictive airway. CNS drive, there is reduced CNS respiratory drive causing hypoventilation and reduced breathing. Example, Biot's breathing. Drugs like opioids, sedative, anesthetics like propofol, midazolam, opioids, they reduced your respiratory drive causing CO2 increase. What is alveolar volume? It is tidal volume minus dead space. Hypercapnia is treated by increasing the minute ventilation, which is tidal volume into respiratory rate. Do not withhold oxygen required to maintain minimum oxygen saturation level in any chronic lung patient in an effort to stimulate ventilation or to reduce hypercapnia. So oxygen is the first treatment. Doesn't matter how much we badmouth it, it is the thing that is keeping us all alive. What are the causes of hiccups? Acute, benign or self-limiting causes and chronic causes. The benign causes are gastric distension, alcohol, smoking, change in environment, temperature, psychogenic. Then there are chronic or persistent causes, CNS lesions, vagal, uremia, hyperglycemia, hyponatremia, general anesthesia, thoracic abdominal surgeries, ear, foreign body touching the tympanic membrane, especially if a ear hair, external auditory hair is touching the tympanic membrane, it can induce hiccup. So uremia, hyperglycemia, hyponatremia, CNS lesion, phrenic nerve irritation, general anesthesia and foreign body touching the tympanic membrane. How do we treat hiccup? Remove foreign body from the ear, swallow a teaspoon of sugar, sip ice water or drink water quickly. What is the drug treatment for hiccup? Chlorpromazine, metoclopramide, haloperidol, nifedipine, valproate, baclofen and gabapentin. Baclofen 10 mg PO is used very frequently. Only chlorpromazine is approved by US FDA for hiccups. Coming to cyanosis, central and peripheral cyanosis are different. Central cyanosis is bluish mucous membrane and tongue due to increased reduced hemoglobin, while peripheral cyanosis is due to vasoconstriction and limited peripheral blood flow. So you know the Russian flag, there is this white, blue, red. So when the vasoconstriction is there, the fingers become pale, then the reduced hemoglobin increases, fingers become blue, finally rewarming occurs and the fingers become red. So remember Weber. What are the differential diagnosis of cyanosis? So central cyanosis can be caused by hypoxemia and abnormal hemoglobin. Hypoxemia like hypoventilation, right to left shunt and VQ mismatch, high altitude. While abnormal hemoglobin like methemoglobinemia, self-hemoglobinemia and carboxyhemoglobinemia cause cyanosis. Peripheral cyanosis is cold extremities, distributive shock and venous obstruction. The causes of cyanosis can be remembered by a mnemonic: cold palms. Cold is for peripheral cyanosis and palms is for central cyanosis. Cold is for cold, obstruction, LV failure and shock, and decreased cardiac output. Central cyanosis is polycythemia, high altitude, lung disease, methemoglobin, self-hemoglobin, and shunt. What is pseudocyanosis? It is a bluish or grey discoloration due to drugs like your amiodarone causes blue man, chlorpromazine, minocycline, amiodarone, and nicorandil, or heavy metals like gold and silver. Remember this with C-man. C for chlorpromazine, minocycline, amiodarone, and nicorandil, gold and silver. The difference is the patient appears apparently fine. The cardiovascular and respiratory exam is normal. The discoloration does not blanch with pressure and it tends to be more intense in a sun-exposed areas. If your patient has carboxyhemoglobinemia, the pulse ox is falsely high. It is going to read the pink carboxyhemoglobin as oxyhemoglobin and will give us 100% reading when the patient's lactate are still high and he is still tachypneic and dying of air hunger. The arterial gas analysis using co-oximetry, it is a specific multi-wavelength measurement of oxygen saturation, will detect carboxyhemoglobin separately. So if you find a discrepancy between the patient's saturation level and the arterial oxygen level, be aware and think of carbon monoxide and cyanide poisoning. If you have a patient with cyanide poisoning, administer IV vitamin B12. And Lilly's kit. What do we have in Lilly's kit? Amyl nitrite, sodium nitrite, and sodium thiosulfate.